right, good morning, everybody. Welcome to this week's It's Worth a Shot. It is Wednesday, April 3rd at 10:30 in here in Honolulu. My name is Jolene Kageyama. I'm the account manager for Hawaii and assisting in Alaska. It is our honor and pleasure to bring this session to you on severe sepsis. And we have an amazing guest speaker that will talk about that in just a second. Mary, next slide, please. As always, our presentations may contain information and/or content supplied by third parties. The information provided does not constitute endorsement or recommendations by Mountain Pacific. Next slide, please. And then just some updates and reminders. It's Worth a Shot will not meet next week, April 10th, due to the CMS Quality Conference. Many of Mountain Pacific account managers will be in Baltimore attending that conference. So if you're interested in attending virtually, you can register at that link and we'll put that into the chat. Mountain Pacific also has an email for immunization questions and assistance. So if you have questions, just shoot an email and someone from our team will definitely reach back out to you. And then the 7th Annual Older Adult Mental Health Awareness Day virtual symposium will be May 2nd. So take a look at that. You could register and take a look at mental health awareness. Next slide, Mary. And from hospitals to schools to long-term care and more, infection preventionists play a critical role in safeguarding public health worldwide. International IP Day is our chance to honor their dedication and commitment to preventing the spread of infections. This Infection Preventionist Day, on this Infection Preventionist Day, make sure you honor those folks in your life and let them know how much you appreciate their dedication and commitment in keeping your residents and your staff safe from infections. You can learn more at the link there on celebrating International Infection Preventionist Day, and that's this Friday. Next slide, please. As always, our housekeeping items, we like to hear from you at the end of the conference, at the end of the meeting. We have a survey, and in that survey, we welcome webinar topics or ideas. You can also drop those into the chat. We will continue these Wednesday It's Worth a Shot sessions. So we love to hear from you. Drop those comments in the chat, additional topics you'd like to see or hear. And you can also put them in the survey that we asked for your feedback at the end of the session. All right, we have a couple polling questions for you. Mary, if you want to queue up the first one. All right. Does your facility use a standardized sepsis screening tool? Yes or no? And if yes, do you have a set action plan in place for when a risk is identified? Okay. There is 49 people on the call today, and we have about 20 people responding. So let's give it a few more minutes here. We'd like to hear your responses or see your responses on these polls. Does your facility use a standardized sepsis screening tool? And if yes, do you have a set action plan in place for when the risk is identified? All right. Looks like we got about 58% responding yes. All right. Mary, you could go ahead and end that poll, and then is there another one, or was that it? And the next polling question, do you provide the following on sepsis? It is a multiple choice question. Training at onboarding, staff education resources are in your common area, annual staff training, or all of the above. We have 53 participants in the call today, so let's see if we can get 53 responses. Okay. So far, it looks like about 26% are saying all of the above. Right. All right, so looks like 29% is showing training at onboarding. 52% is annual staff training. And 24% of you have indicated all of the above. Mary, we can go ahead and end that poll. And then next slide, please. All right, just to give you an update on our weekly influenza, see lots of green, which is minimal outbreaks across our states. That's trending is down, so that's good. Next slide, please. And this is our weekly COVID-19 snapshot. And so you see the trending in positivities are also declining, as well as the trend in percentage of emergency department visits have declined. You see Alaska is showing substantial decrease in their outbreaks, as well as some of the other areas of our states in Wyoming and Montana. All right, next slide, please. All right, I want to introduce you to Rachel Kincaid. She is the Chief Nursing Officer at South Peninsula Hospital in Homer, Alaska. She is a doctorate-prepared nurse practitioner with 15 years of nursing experience. Born and raised in the Carolinas, Alaska is now Rachel's home. It is her honor to support and shift nursing practice toward a healthier and more sustainable future. Rachel and her husband have 6 children. In addition to evidence-based and holistic healthcare, Rachel enjoys the outdoors, skincare, politics, pro basketball, houseplants, and the practice of gratitude. And Rachel, welcome to It's Worth a Shot, and we're very grateful to have you here on today's session to talk about sepsis and septic shock. And I'll turn the mic over to you.
Thank you, Jolene. I actually wanted to just thank you publicly. The way that we connected recently was through some support that you and your team gave us for an outbreak. And our team, most of whom are represented on this call, I think are really hard on themselves in the best way in terms of taking care of the elders in our nursing home. And they come prepared with a lot of tools, and it still feels overwhelming and discouraging, you know, when our elders get sick or we have a COVID outbreak. And it's just really helpful to connect with other folks. And so when you and I were talking about COVID outbreak, follow-up, et cetera, we also kind of shifted over to just an uptick that we're seeing statewide in Alaska in terms of early sepsis in elders. And so some of this content might feel recycled to those of you who have been on any of our previous calls. I've shared with Telegen, and I've done a quality cafe with AHA and presented down at the Rural Healthcare Conference in Florida earlier this year, but hopefully some helpful content nonetheless, and maybe you'll pick up something new. So thank you for having me and for that connection made over a sort of stressful situation. Mm-hmm. And that's one of the things I wanted to focus on in this talk was the concept of radical transparency. I'm a big fan of transparency. I know that all of us have access to data and stories in terms of the care that we provide. And I believe that hard and sometimes tragic outcomes, as awful as they are, can actually make us better if we're willing to humbly look at ourselves and our practice and really take an evidence-based approach to a root cause analysis. And that's what we did 2 years ago. So my background is that I came up to this beautiful town of Homer, Alaska, to be the nurse practitioner for our nursing home. And so I'm going to share a little bit about our setup and how everything works in our hospital. But I then, after a couple of years, transitioned over to the chief nursing officer role. And 2 weeks after I started that role, a patient in our hospital died of sepsis. And that patient also happened to be an employee. And if you work in a small community and in a small healthcare facility, not only every patient matters, but the patients that are also your coworkers, those hit really hard when the outcomes are bad. And so we took a pretty ruthless approach, a results-driven approach to looking at every single process, order, plan of care, human who touched the patient along the way. And there was no one specific fallout in terms of sepsis care, but we found areas in which we could improve. And so from that point on, January of 2022, we've been pretty obsessed with sepsis care. And that's, I think, what got us to the point that we're at today, where we're able to share some of our results and the reasons and the measures by which we got here. And so that's why I just wanted to like stay open with you guys. It was actually a really sad story that got us here, and we want that to be part of our story as well. Next slide, please. So what is a critical access hospital? A lot of you are very familiar with it. I come from Charlotte, North Carolina, the land of 1,000 teaching hospitals, 1,000+ beds, et cetera. So this was new to me. And now that I'm here, I love it so much. I love locally coordinated. I love independence. I love being able to keep our patients local and serve our community in a way that is really intimate. It also holds us more accountable, as I just explained. So I think that makes us better, but I'm crazy about critical access designation. So to explain it to those of you who might be unfamiliar, you can't have more than 25 licensed inpatient beds. You have to be at least 35 miles away from the nearest healthcare facility. We're 75 miles away from our nearest, which is Central Peninsula Hospital, our sister to the north. We do have a level 4 trauma designation. Our average length of stay has to be less than 96 hours over the course of a year. A lot of you know that at the federal level, they're looking at getting rid of that. Currently, our service area is about 15,000 people. And just so that you can get a picture of what our hospital is like, our ER is 9 beds, and then it's connected to a big loop. That loop goes through a 2-room operating room suite, as well as 3 labor and delivery beds, 18 acute care beds, any one of which can be ICU. And then if you keep going down the hall, we have a 28-bed long-term care. I think it's important to note that although we're licensed for SNF, our long-term care beds are almost always filled historically, and they are almost always filled with folks that are kind of in that twilight phase of life, where I explain it to folks as they're too sick to live at home and they're really too healthy for an acute inpatient rehab. And so we're in that intermediate care level where most of our folks have some type of cognitive impairment and require assistance for all of their ADLs. And just so that you have a picture of what that looks like, those folks are coming to us, as most of you who are in nursing home or elder care know, more acutely ill. They're coming to us younger, with more complex comorbidities. And so we are seeing an uptick in sepsis for them as well. And then for folks that don't really understand the critical access designation, I tend to explain what our primary care services look like. But basically, we hang out on the side of a hill and we rent lots of properties in a 2-mile radius. And we try to provide as much full spectrum outpatient care as we can outside of our hospital building. Next slide, please. Okay, so a lot of the questions that I've gotten over the last couple of years of this work, I'm going to get to the nitty-gritty at the end. And I would be remiss if I didn't say publicly, thank you to Anna Leewald, our infection prevention nurse who is on this call. She has helped me tremendously in this work. Joyce Ryder is also on this call. She works in our nursing home, but she was instrumental in building our sepsis protocol. And also Sue Schober, our quality director. A lot of these folks off and on throughout the years will tell you that we were working toward a cohesive sepsis program without the championship support from all of the different stakeholder groups. Sue has put it really well in the past. It's really hard to do the work if everyone isn't owning it in their own areas. And so one of the ways I think that we've really nailed this is from the senior leader level. Our CEO is very focused on our sepsis work, specifically, having to sit across from a spouse whose partner died of sepsis. That is sobering. And to be able to say, we're going to make this make us better is a promise that we would like to deliver on. So in 2022, in January, our CEO Ryan Smith asked me to put a new focus on sepsis and kind of rally the troops in terms of our in-house program and also the publicly reported data on CMS. And so one of the things I think is really powerful, oh, I think there might be a typo here, our chief medical officer, our CMO, and myself, from the clinical perspective, have taken ownership of the nursing role and the medical staff role. I speak clinical as a nursing administrator. I am a nurse practitioner. I have that background. And so that helps in terms of earning some credibility. And then having your chief medical officer who has worked in both the hospitalist space and the family medicine space, has a lot of respect in that area. And so we have kind of, we've held ourselves accountable to staying up to date on the data, the committee work, and then we report all of that back out. Another thing that we do, I think, that matters is we talk about sepsis everywhere. And you'll see kind of examples of where down the road. But in terms of engaging leadership, if you're talking about the topic that you care about everywhere, eventually they know that you care about it and they start to care about it as well. And so it's my dream for us to stumble upon one of our valuable housekeeping staff or, EVS techs and ask them, like, what are you doing today by mopping this floor and preventing sepsis? Like, that is just a beautiful picture of what it looks like for all of us to own it. And so when you change the language, you start to change the culture. And when we talk about sepsis, even in places in which it typically wouldn't matter or wouldn't come across the table, I think that's important as well. So every week I am responsible for reporting our sepsis data to our senior leadership. And every month I'm responsible for our answering of all sepsis data to our board of directors. Next slide, please. How do you meet as a committee? How do you stay organized? How do you talk about goals? How do you hold people accountable? Lots of really good questions. I love meeting schedules. I love consistent agendas. Anna Leewald, like I said on this call, our IP nurse, has taken over our sepsis committee. She runs a really good meeting. They're 30 minutes long. They had the same agenda every single week. At the beginning, we were meeting, we meet monthly now, but at the beginning we were meeting every week. And it was just kind of a shotgun approach and we just went for it. And I went to every single department that was involved in sepsis care at all. And I invited them in person. I said, I need you at this table. We need to talk about what it is that we're missing. We need to talk about what it is that we need to improve. We need to talk about every single case that comes through the hospital that looks like sepsis. Will you show up? And so after a couple of years, we've been able to go to monthly. Anna keeps us on track with an agenda, and then we ask each department to speak to a roundtable discussion. So we'll ask pharmacy, is there anything you're learning or anything you see wrong with the way that we're treating sepsis, or lab, like what's happening in the lab? Talk to us about blood work, et cetera, et cetera. And the statistics are reviewed, like I said, outside of just the nursing world or the healthcare world. We talk about them in managers meetings. We talk about them with our board of directors. We teach them what to ask us. We want you to care about this. We want you to ask us what we're doing in this topic. And so again, giving them the tools to kind of buy in helps us maintain that momentum. Next slide, please. Any challenges? Yes, always. And when you're trying to take on a CMS publicly reported topic, you are often faced with pushback that is valid. And that is that some of this data is outdated. Like we talk about procalcitonin right now, even though we are measured on lactate. We talk about what clinical practice looks like. My outcome wouldn't change because the plan of care wouldn't change. So why do I have to document it in this way? And that can be difficult. That's why having a champion in terms of nursing and physician documentation is really helpful. Also easier to sit in a group and review a case, all of the notes, all of the labs, all of the follow-up, and kind of put together what you think the provider was doing. It's harder to do that in a chart. And so that's why we value getting together as a group so we can talk through what happened, how did a case pass or fail, and who needs to follow up on whatever item was missing. Another really important reason for gathering as a group. And then the differential diagnoses. So one of the things you're going to see when I talk about the the step-by-step tedious approach to sepsis management is that we look at every single case that qualifies for SIRS criteria or infection. And we've had some rather humorous cases. Somebody comes in with their vital signs out of whack, and it's because there was a dislocated shoulder or something that had nothing to do with infection. But you have to start somewhere. And so we decided to cast a wide net at the very beginning. Next slide, please. So how has the leadership engagement and outreach, et cetera, led to an improvement in our work? I think the data shows that it's working. Our scores on CMS Care Compare went from the 50s to the 90s. We hit 100% for meeting the standard of care for severe sepsis and septic shock in Q4 of this last year. We do have an added sense of urgency and emotional connectedness and importance to the work now that I don't know if we had before, and that's okay. And we're also looking at different ways to incentivize our scorecard. So every year we submit a scorecard to the board of directors to tell them the things that we want to care about and that we want them to hold us accountable to. And they reflect our strategic plan, and they cover 5 topics that you'll see in a minute. And so now that we've kind of familiarized that flow and communication with administration, medical staff, the board, our staff, I think it's now time to talk about how do we help everyone care about it together. And oftentimes that looks like financially incentivizing different elements on the scorecard. So that's more to be determined, but I know a lot of hospitals are doing that, and it's definitely something to consider. Next slide, please. This is our strategic plan. This is what we put on nearly all of our meeting agendas. This is the language that we use when we talk about different initiatives or programs that we have. When our management team and different directors want to work on quality improvement, or they want to work on a specific project that staff suggest, we run it through this lens. Like, where does it fit in our strategic plan? And so, I literally read it out loud. So whenever I teach on sepsis or explain our sepsis work to stakeholders, I will read it under the clinical excellence and service headline. I will say, using evidence-based practice, we at South Peninsula Hospital are dedicated to achieving consistent and demonstrated excellence in clinical quality and safety. So we're going to talk about falls today, or so we're going to talk about sepsis. And that really helps kind of define why we care about what we care about and how much energy to put into it. Next slide, please. So this is the poster. This is an academic poster for those of you who are familiar with the concept that I put together with a bunch of really smart people at our hospital. I just happen to be the lucky one that gets to present it, but thank you to all of you who helped us put work into this. It basically explains the journey over 1 year in terms of 2022 to 2023 and how we were able to see defined improvement in our sepsis scores. And so the part that a lot of folks care about is asking, like, how did you do it? Tell us the step-by-step. The core elements bundle just came out through the CDC in the last year. I highly recommend familiarizing yourself with that. We loosely use that because I kind of started around the same time that they did, and we were fumbling in terms of trying to come up with step-by-step improvement methods. But our main methods are, number 1, an interdisciplinary committee that meets regularly. Number 2, physician championship, making sure that doctors in the ER agree with doctors in surgery, agree with doctors in acute care, and then those physicians are invited to the table to look at our protocols, to look at our cases, to give feedback to their own colleagues when there is an opportunity for improvement, rather than it being me or a member of the quality team writing them, an email. It matters when peers are able to give peers feedback. Number 3, real-time chart review. This is where Anna is just so helpful. In addition to the screening tool that all of our nurses use, if one of those screening tools pops positive, it triggers an alert that goes to our inbox. We're converting to Epic next year, but right now we in the hospital are on point-click care in the nursing home, and there is no way to alert staff to any sepsis there. They just have to do, case reviews on their residents. But in the hospital, in the ER, we are able to get a CPSI evident alert that basically kicks to a private inbox. And that alert will say, concern for infection or change in labs or change in vital signs. And that will trigger us to go in and do a manual review. And if we're able to do that within a couple of hours or even a day of the patient's case, then we're able to catch things obviously much quicker for intervention, but we're also able to follow up a lot quicker. Because as you know, the data can be 1 to 2 quarters behind in terms of CMS. And I don't think anyone wants to hear about an area that they need to improve on that occurred, 8 months ago. And so it's been really helpful when we say, hey, a couple days ago, you didn't order a lactate. The case passed because of this, but next time, please consider a lactate, blah, 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 blah. So that's one thing. The other part of real-time chart review is that we were able to pick up on who was really knocking it out of the park in documentation. And so we were able to develop numbers 4 and 5, which are a nurse-driven protocol, and educate the nurses on how to put in their own orders that were approved by our medical staff in terms of clinical workup when they're concerned for sepsis, so that by the time they call the physician and say, I am concerned for sepsis, these things are already pending. What would you like to do next? And then number 5, the physician documentation. We've been able to build templates. Our informatics team has gone to the doctors that are really nailing it and kind of duplicated the way that they chart on a sepsis patient. And so now they use that template, which is really helpful for our review and the nurse to follow up on in terms of what the physician was thinking and what the plan of care should be. So I think those 5 things, the committee, physician championship, real-time chart review, RN protocols, and then the doctor templates have really helped us systematically, I think, overhaul our approach to severe sepsis and septic shock. So that's the end of my slides. I would love to entertain questions or feedback if you have any. Otherwise, you can have a few minutes back in your day, but I really appreciate you giving me the time to share.
Rachel, thank you so much for sharing that information on the efforts that you did in focusing on sepsis in your community. Question for you is, how did you go about, you identified the issue, but then how did you go about in onboarding, training, competency testing of all of your staff, including your EVS and your CNAs who are providing that direct patient care?
Yeah, that's still in process. So it happens at the floor level with the clinicians who are providing care in terms of their onboarding. It also happens in annual skills fairs. And then I would say in our nursing home side of things and the long-term care, Point Click Care has an amazing communications section, kind of like a bulletin board for just-in-time education, and then monthly staff meetings where we can review, hey, we're seeing this, please pay attention to this. Anytime we roll out anything new in terms of a protocol, that's done at the bedside in most of our departments where they are physically doing teach back with one another and then getting signed off competency wise on that skill. And so in our acute care setting and the ER setting, that's the goal for sepsis awareness in terms of like, when you screen the patient, this is what you're looking for, and this is what you do next. Now tell me how you're going to use the protocol, or show me. We had a little shot clock for a while. If anyone's ever seen one of those, it kind of takes you step by step through what you need to do in hours 1 and 3 and 6, etc. And so we use that now to audit our work, but they're available all over the hospital in the inpatient and ER setting to kind of guide the nurse through next steps.
Very good. Thank you so much. Any other questions? You can bring yourself off mute or drop them in the chat. I am not seeing anything else at this point, Rachel. So Mary has placed the evaluation into the chat. So if you click on that and take a few seconds to complete that evaluation, we do appreciate that. Mary, next slide, please. And then just a reminder, next week we will not have It's Worth a Shot. So we'll see you all in 2 weeks, Wednesday, April 17th. And
the next It's Worth a Shot will be on C. diff, brought to us by Kelly O'Leary, which will be, yeah, sorry, for chiming in there, which will be on April 17th.
All right, everybody, thank you so much for your time, and happy hump day.